I think stigma is probably one of the most serious issues that's affecting TB management efforts, management and care efforts currently. The problem is that if stigma is not addressed at the very early stages of the nurse training, then nurses go into their service with the same amount of stigma as any layperson. So if stigma is pervasive in the local community, then the nurse will carry that into service. The responsibility lies in many areas. So we have nurse lecturers who have very old views, perhaps they haven't had any updates about TB, and they really don't understand well enough, and they kind of reinforce the stigma that the nursing students are feeling towards TB. We then have, when nurses are then deployed, when they finish training, they are very upset. Many nurses are very upset if they're put in the TB ward. And also we hear numerous stories of nurses actually being deployed by managers as a punishment if they're difficult or if they're not so well able to do a job. It's almost a punishment to be put onto the TB unit. So we have a very serious problem that needs to be addressed at every level, in nurse training, pre-service training, in-service training, with nurse managers. What we find with our training program that we do, which is very nurse-led and aims to be very patient-centered, is that when we discuss stigma, the roots, the causes, the consequences, and then what we can do about it, we find a real sea change in nurses' attitudes. And because it's embedded in a full course of activities to improve nurses' capacity for TB, the nurses, by the time we talk about stigma, nurses are very confident in talking about TB, and they start admitting their own feelings, and it's a very powerful sharing. And we've had nurses who have actually felt, they report having felt very bad about going to work on the TB unit, but once they're there, once they receive our training, they feel more confident. And one of the outcomes from our training has been that nurses report feeling more confident in talking to their colleagues, to debunk stigma, debunk myths about TB, more confident in talking to communities and their colleagues, and they just get a much better feel for the work that they're doing. We had just 2 days ago, I was talking to Sharon Finn from South Africa, who has been doing some training with nurses who were doing some intensified case finding in KwaZulu-Natal, in a province in an area in Durban. And they were doing house-to-house calls, and they were very reluctant to do this work. They were not happy about being assigned this task. They were very reluctant. She did the training. It's 4 days training. So the nurses received information, were able to work through the information, discuss it, really work out how it got into their practice, how it related to their practice. And having done this training, she said that they went out, they were very keen, they really became very strong advocates, and now many of them want to stay in TB and work more in TB, and are very keen and are very passionate now to work in this area. Because at the end of the day, TB is curable. People do not need to die. People do not need to suffer unnecessarily from TB. If enough nurses in primary care and the general clinics are well informed and confident in managing TB, in talking to communities, in finding TB in their patient community, then we will have a much more effective program. Yes, I would absolutely say that infection control has two elements to it. In one element, people are scared to work in TB because of the infection risk. So you have to make sure that you have proper elements in place for good infection control, but not just that you have a series of instructions. You have to make sure that nurses and other healthcare workers understand how TB is transmitted, so that there is a reason for every step they take in infection control. So if some people are not happy wearing masks because they feel that stigmatizes patients, the point is you should not expect any healthcare worker to go to work and expose themselves to a disease. So what we need is the proper and appropriate use of masks, so you can justify where you are wearing a mask in one situation and not wearing a mask in another. So people really, and to be honest, the risk with transmission is in people who are not diagnosed, when often you're not wearing masks anyway. Because once you've diagnosed TB, once a patient starts treatment with TB, the infection risk is much, much lower. So it's really in the community, it's about early diagnosis, it's about confidence, and it's about having an effective infection control policy so that nurses feel confident in working in the unit. And confident, most importantly, to spend time with patients, because this is a really key issue, that patients feel cared for. If nurses feel careful, they will be able to care for their patients. One of the things that we're really campaigning about from the ICM point of view is to have proper representation of healthcare providers at all levels. So when a new unit is being designed, then the nurses who are going to be working in that unit need to be consulted to say, yes, this is going to work, or no, it would be better to have something slightly different. The nursing station would be better off in this place, or it needs to really be considered about the day-to-day running of the unit, because otherwise it will just be changed, or it could end up being dangerous when it doesn't need to be. Then in terms of policy, obviously you need to engage with the people who are going to be implementing the policy. That's how you get people to comply with instructions. If they understand why there's a guideline, if they've had input into how things should work, then they're much more likely to take ownership of that and behave in a way which reflects good practice. Well, the best thing about working in TB is that you can cure people. It's one of the very few areas where you know that if you find somebody, even if they're very sick, you have a great opportunity to cure them. I also like it because you have an opportunity to get to know and develop rapport with patients, so you really work through this whole experience if you have the ability to do so. On the other hand, if you're working in TB and you're very overstretched and nobody's listening to you and you're trying to deliver care that you're not able to deliver, that's very frustrating. And for many nurses that ends up with nurses taking out on the patients, and then you get this terrible rapport and then things go horribly wrong. But I know many nurses all over the world who are very passionate about working in TB, who really love their work and really want to do their best for their colleagues and obviously fundamentally for their patients and community.